Welcome to the webinar, Clinicians and the Language of Nonverbal Communication. It's not just what you say, but how you say it. I'm Barbara Lewis, the managing editor of .com, and joining me today is Joan Lowry. And let me tell you a little bit about her background. She has over 30 years experience of working as a professional communicator in several areas of communication skills training, including impact communication, listening, media training, executive coaching, creative training, cultural change seminars, and career transition planning. So she's pretty busy. She also has experience as an award-winning broadcast and print journalist for news organizations such as CNN, Associated Press, CNBC, TV, and the Discovery Channel. Welcome, Joan.
Thank you, Barbara. I'm delighted to be here. I hope my audio is okay.
Sounds good.
Okay.
So I just want to say a couple things about the webinar. It will last about 30 minutes, and a recording and a PowerPoint will be available on the .com website afterwards. And at the end of the webinar, you're going to receive a code for a free 1-month trial subscription to .com. So if you would like to ask any questions, you can put them into the chat box, and I will ask the questions of Joan. And if we don't get to your questions today, then we will get in touch with you. Joan will get in touch with you.
Yes.
So let's get started, Joan, because we've got a lot to cover.
We have a lot to cover. So thanks, Barbara, and welcome everybody. I want to begin by stating that most, if not all of you, are aware of the significant body of research that's been conducted on physician-patient communications. And we know that effective physician-patient communications results in a lot of wonderful benefits. And since we're talking about nonverbal communication, which is 2/3 of the 3 channels of communication, those being vocal, verbal, and visual, I thought I might just start by reviewing what some of those benefits are. So I'm hoping, do I have the mouse, Barbara? No, I don't. So if you could give me the mouse, I will start talking about why does nonverbal communication matter.
Okay, you do have a mouse.
I do?
You need to accept it. Mm-hmm.
Oh, where do I accept it? Where do I accept it? I'm not seeing that.
There should be something. Yeah, you were moving the mouse. Yeah, you're moving the mouse right now. Yeah.
Oh, okay. Let's see if this is, oh, here we go. Okay, here we go. So why does nonverbal communication matter? Just to go over these quickly, we know that it results in improved patient safety and satisfaction, in increased adherence to treatment, in improved diagnostic accuracy, and it also enhances empathy. And I just want to say a few words about empathy because we know how powerful that is in things like reducing A1C, blood pressure, LDL cholesterol, recovering from colds. And empathy in large part is communicated through the nonverbal realm. A warm touch, a warm look in the eyes, a warm tone of voice, all of that communicates empathy. Some other things that we know about communication having a positive effect on it results in better HCAP scores, reduced potential of lawsuits, and improved collegial relationships, which lead to enhanced career satisfaction and a sense of purpose. So lots of good things around why nonverbal communication matters. I want to go over the objectives real briefly for our time together, and then the agenda, and then we'll plunge in. We have a lot to cover. Okay, so what I hope to do is twofold: to explore the nonverbal channels of communication and to review relevant research on the impact of nonverbal communication on patient satisfaction and clinical outcomes. And here's our roadmap. We're going to start by talking about building trust and believability, which is essential to establishing positive relations with patients. Secondly, we'll go over what I call the anatomy of nonverbal communication, which includes both the visual and vocal channels. Thirdly, I'll present relevant research, and we probably won't have time, but I'll try to cover this within the body of my talk: cultural differences in nonverbal communication. I want to start with a quote that I really like that was developed by Nalini Ambati and Robert Rosenthal, two social psychologists who've done a lot of significant work in physician-patient communications. So what they said is often it's not what providers say, but the manner in which they say it that leads a patient to trust or like or dislike them. And by manner in which they say it, I want to call attention to the fact that we're not just talking about the vocal realm, we're talking about the visuals. And if you look at this picture in front of you, you see that the doctor has great posture. She and the patient seem really in very good alignment. They're smiling, they're sort of mirroring each other with their facial expressions, and clearly there's something nice going on between them. Okay, so let's move into trust and believability, and I want to present some seminal research that was done in this field by Dr. Albert Mehrabian, a social psychologist at UCLA. He's now professor emeritus at UCLA. And what he was looking at was what happens when people are getting a message they just don't believe, what he called an incongruent message. So for example, if I said to you, "I'm really happy to be here," I hope I didn't break any eardrums. My vocal, how I said it, does not mesh at all with my words, my verbal. And if you could see me now in the visual, it would be completely incongruent. So Dr. Mehrabian was looking at, in these circumstances, which are usually more subtle, how do people assess what the truth is? I think it's particularly relevant to physicians who work with patients because when you come into an exam room or you're giving a diagnosis or you walk into a hospital room, people tend to be on guard and nervous and wondering, can I trust you? Should I adhere to what you tell me? So I think this work is particularly relevant. So the three dimensions, the visual is body language. We'll get into that much more in a few minutes. The vocal is not what you say, but how you say it. And the verbal are the actual words that you use. So I'd like you to just take a few moments and write down how you think the participants in his study weighted each of these categories when they were trying to figure out what the truth was. So just take a few moments and then I'll share that with you. Okay, so these were the results. This research was done over 50 years ago. There's nothing that has supplanted it to my knowledge. And so I believe the order you're seeing would be correct, but here's what the numbers were. 55% for visual or body language, 38% for vocal, not what you say but how you say it, and 7% for the actual words. Now this is kind of shocking to a lot of people, and I want to highlight two particular areas of this study. So the vocal realm, and I've been doing an informal survey on this with clients and physicians for a couple of years now. The vocal realm I have nicknamed the unappreciated stepchild of nonverbal communication. Most people are very unaware of how they are communicating vocally. In other words, they don't hear themselves. It's not in their training. And if we're going to be good vocal communicators, we need to start hearing ourselves and practicing delivery in a way that's going to maximize the alignment of the message. The 7% that's the verbal makes people feel sometimes like, what are you talking about? What I'm saying doesn't matter? Not at all. The point here is that the verbal, the messages you give to people, are delivered through the 93% that's comprised of the vocal and visual. So if you're doing something distracting, that's going to get in the way of your message. If you're aligned, it's going to help the patients really get and understand what you're talking about. And especially in the short amounts of time you have to spend with them, it's very important to have this alignment. Now, what happens if you're not in front of them at all? You're talking to them on the telephone. You're just a disembodied voice like I am right now. In that case, people are making up pictures about what you look like, and we've extrapolated and estimate that 85% of your communication is how you say it. So that's pretty powerful. That's the vocal dimension. and 15% are the actual words that you use. So we're talking about some pretty powerful information if you're going to be an effective communicator. Now, before we get into breaking down the visual and the vocal dimensions, I do want to highlight that communication, and nonverbal communication, of course, is a two-way street. So for today's session, I'm focusing primarily on how you or I communicate, becoming more aware of what we do nonverbally, and then being more facile at it. But in the real world, when you're with patients, being able to read their nonverbal communication is essential. It can help you with a diagnosis, it can help you get them to reveal more, and it can certainly help you assess whether they're understanding what you're saying. You know, the eyes glazed over are a good indication that they're not getting it, or their tone of voice. So it really is a two-way street. So let's start with the visual dimension. And the first thing I want to talk about briefly is facial expression. The face tells so much, and there's a lot to our faces. We have jaws, we have lips, pursed lips, we have brows, we have eyebrows, of course we have our eyes, and we even have our nose, which can make funny faces. And if you think back to the picture I showed a few moments ago of the doctor and the patient, their facial expression was very revealing that they were in rapport. So it's very important to understand what your face is doing in the moment. Secondly, of course, most important, I think, in the face is the eye gaze. They say that the eye is the mirror to the soul, and it's a very powerful vehicle. Now, the eyes are muscles, and we can get more facile with our muscles. And I'm going to ask you, as you sit there, to try a couple of things with me. So we talk about, when I'm doing training, soft eyes. I'd like you all to do whatever you think it takes to make your eyes look soft and to experience what that feels like. To me, that feels like a more compassionate glance. Now I'd like you to create with your eyeballs beady eyes, intense eyes, eyes that are really, really intensely looking at somebody. And you can see how that feels. And finally, I want to have you experiment with what I call smizing, smiling with the eyes. But before you do that, I want to tell you who I learned it from. I was watching Larry King a few years ago when he was on the air, and he had Tyra Banks on her show. And he asked her, he said, you know, you always look like you pop when you're on television or when you're in photos. Tyra Banks, excuse me. He said, what do you do? And she said, Larry, I smize. So without smiling with your lips, which is going to be hard to do, I'd like you to take a moment and just try to smile with your eyes and feel what that looks like. So these three little exercises we just did hopefully demonstrate to you how much animation we can really give out or take in. Now it says the look of listening, and what do I mean by that? How you are looking when you're in the process of communicating or listening to somebody also either opens the door on communication or can shut it down. So for most of us, our look of listening is fairly habitual. So becoming aware of how you are looking at somebody, and are you compassionate? Are you inviting? Are you curious? Being aware of that is a very useful thing to do in the communication process. Okay, the next area I want to talk about in the visual are gestures. And we know that physicians have a limited amount of time with patients. So being able to use gestures choreographically can really help patients to get the message. For example, right now I'm going to be using my right hand. I'm going to put my right hand to the side and say, you know, on the one hand, you can do this. On the other hand, you can do this. Or we can bring these options together. I'm bringing my hands together. Those kinds of gestures in congruence with what you're saying can really help a patient get the message more fully. I want to talk about something else with that, which is pointing. I'd like everybody to point their hands, just point it at the screen, and see how authoritative and almost accusatory that feels. Now take your same hand and hold it upward with the palm up like an invitation. That's much preferable to the pointing hand. It's much more preferable. It's inviting somebody to collude with you in a process. Okay, extraneous movements are distracting. So things like nervous tics, playing with your hair, fiddling with a pen, your leg going up and down, all of that delivers a message that is distracting at the very least, and can also indicate that you're nervous or you're impatient or you're rushing them. So being aware of your extraneous movements, which also are often habitual, is important. Posture. We saw in that picture of the doctor and patient that I showed a while ago how composed and confident that doctor looked. She was just standing there, confident, credible, as opposed to slumping shoulders, not looking directly, not facing the patient directly. With regard to posture, just simply standing with balance between 2 feet with your knees slightly bent is a good way to present yourself. Sitting versus standing. We're going to get into some research about that in a moment, but I want to talk a little bit about sitting. I work a lot with people in a variety of contexts on their communication skills, and I have them sit in the forward half of their chair with their feet planted on the floor. It may seem strange at first, but what we're talking about here is forward energy. It gives a feeling of presence to the other person and also to the person who's doing it. So your hands are in your lap, ready to be used as you communicate. Standing, I already talked about. Walking is very, very important. How do you walk into the room? What's your entrance like? What is your exit like? If you're coming into the hospital room and you're in a hurry and you kind of breeze in, that gives an immediate first impression to the patient that you're nervous or in a hurry or preoccupied. So walking into the room with confidence and intention and standing at their bedside and greeting them and leaving with that same confidence and intention is recommended. Proxemics, which means the use of space. That differs in different cultures. Some people are more comfortable when you get very close up to them. Some are less comfortable when you do that. But being aware of how are you moving in the space? Are you standing at the bedside of the patient, or are you standing at the foot of the bed? All of that gives a very distinct impression on the patient. Touch, and that's culturally sensitive. In different cultures, some are comfortable, some aren't. But in general, being sensitive when you're touching the patient. So for example, if you're doing an H&P, rather than just put your hands and start palpitating their liver or their stomach or touching their heart, ask for permission. Tell them what you're about to do so it doesn't come on as so shocking to them. Appearance and dress. You're probably wearing your white clothing, but being aware, is your hair, if you have hair, is your hair kempt? Is your face clean? All the things, you know, if you've come in from the outside on a hot day like it is here in Florida, is the oil on my nose gone? So just being aware of your appearance definitely has an impression on the patient. EMRs, electronic medical records. We could go on for a very long time about this, and many doctors have called it the bane of their existence, as have many patients. I do want to point to the fact that there's been a lot of important research done on how to use EMRs effectively. So for example, can you structure your tablet or your PC so that the patient can use it as an educational tool with you to look at the medical tests? Or can you say to the patient, I'm just going to catch up on what the tests say, and then I'm all yours. So look at it, turn around, and be with them. I've been reading where some doctors are just taking notes, hand notes, and then afterwards inputting it into the PC, and more we're seeing scribes to make that communication with patients more intimate. And finally, in the visual channel, multitasking, and that's gone viral, and I would say it's a pretty negative part of nonverbal communication. If you're looking at your watch, you're looking at your beeper, you're distracted, patients pick that up. And again, that affects their trust, their sense of your caring. I want to present some research that was done at Kansas University Hospital on how patients perceive how much time physicians have spent with them when they're either sitting or standing at their bedside. So in the first group, physicians stood for 1 minute and 28 seconds on average at the bedside of post-neurosurgical patients. The patients perceived that these visits from the physicians actually lasted 3 minutes and 44 seconds, excuse me. Now, the physicians that actually sat at the bedside sat there for slightly more than 1 minute, so it's less time than the other. However, the patients perceived that their visits were 5 minutes in length, which is 40% more time, all perception, than the physicians who were standing. They perceived 40% more time was spent with them. I want to read a couple of other significant findings from that study. As a result of the increased perceived length of time with the seated physicians, these patients were more satisfied with their care and reported having a better understanding of their condition than patients who met with the standing physicians. 95% of patients who visited with the seated physicians had positive post-visit comments. However, when it came to the standing physicians, only 61% of the patients' comments were positive. So in summary, when patients think the doctor is in the room longer, they express a better understanding of their condition and greater satisfaction with their care. So that's something to really think about, and it's an easy fix if you don't have a chair in the room that you can sit on. I want to share some information that was done with physical therapists around nonverbal communication. So physical therapists were working with geriatrics patients, and the first group exhibited of the physical therapists distancing non-engaged behaviors, such as not smiling and looking away from the patients. This is what they found: that their distancing behaviors strongly correlated with both short and long-term decreases in patients' physical and cognitive functioning. That's frightening. On the other hand, engaging physical therapists, and by that they mean facial expressiveness such as nodding, frowning, even the furrowing of brows, smiling, these physical therapists, the results with the patients was associated with short and long-term improvement in their functioning. So this is quite dramatic. I want to present a couple of quotes from Dr. Carol Casella, who's an author and an expert on nonverbal communication. Her advice is to stop, look, and listen. She says, stop facing the computer. Look at your patients while you talk to them. And thirdly, listen for more time than you talk. Another quote of hers I'd like to share with you is this. She says, body language can say more than words, but you'll miss it if you aren't looking, and your patients can't ask you questions if you don't give them space. Pause. So with that, I'm going to go into the vocal dimension. And vocal dimension, the vocal channels, often called paralinguistics or vocalics, how we say things. And earlier, I talked about that as the unappreciated stepchild of the nonverbals. Volume. Volume is critical. Are you too loud? Are you too soft? Does your patient have a hearing disability? Knowing that you're striking the right note is really, really important, because most people are not comfortable telling you, you're talking too fast, you're talking too loud. They just are not comfortable doing that. Secondly, pitch. Do you talk too loud, too high, too low? Your tone. Tone of voice. Is your tone warm and friendly, or is it cold, or is it, God forbid, monotone? All of those things have an impact. Speed. Speed is really critical. I find in my trainings that most people speak way, way, way too fast, and they're hard to understand. If you have a patient that's ill they may have an even harder time understanding if you're speaking really quickly. So speaking at the right speed and hearing yourself so you know how to slow down, that's often difficult for people who aren't trained as professional speakers. Clarity and articulation, that is so important, and so many people swallow their words. They don't speak clearly enough. So being very clear that your patient understands what you're saying vocally. Vocal emphasis. By that I mean, do you color your words to emphasize key points? So I just said, do you color your words to emphasize key points, as opposed to, do you color your words to emphasize key points? You see, that would just go right by you. So being aware that you're an educator, and it's really important for you to work on all channels when you're trying to educate patients, and certainly to get them to adhere to your recommended protocols. All right, intonation pattern. We all have the melody of our voices, and we can vary it depending on who we're with. So being aware of what it is and gaining flexibility in that. And then there's the pause. And I'm going to take a moment to just pause. I've been going fast because we don't have a lot of time. But pausing is so important, not only to help your patient ingest what you've just said and maybe reflect upon it, but perhaps more importantly, or equally importantly, to give them an opportunity to ask a question, to provide feedback. Their feedback and information can help you get the correct diagnosis. Quasi-verbal behaviors are distractors. Interrupting people gives them the message that what you have to say you think is more important than what they have to say, or may give them an impatient read. If you are hesitating when you say things, it makes you look like you're not very sure of what you're saying. Sighs. Sighs can be natural and authentic, or they can indicate irritation or frustration. Reading that in your patients is also important. Fillers is a distraction, and there's a host of them, like oh, so, well, what, okay. Being aware of that, because otherwise fillers become big distractions. They start counting how many times you've said We'll talk about accents in a moment. A lot of people, I find, trail off at the end of their sentences, as opposed to trailing off at the end of their sentences. So being aware of completing your sentences and being totally audible when you're communicating. Trendy rhythms, such as uptalk, that's become viral in our society, when rather than be declarative, people say things in a question. And you may want to do that on the outside, especially millennials do a lot of that. But it's kind of strange if you're saying your blood pressure is really high. The patient's thinking, are you telling me or asking me? So being aware of that. Vocal fry is another strange, phenomenon that makes people sound very bored. If you want to use that when you're in your social life, fine, but when you're practicing as a clinician, it gives a very incongruent message to your authority. Sound interrupters, cell phones, beepers, loudspeakers, they all interrupt what you're saying. And accents can be intriguing and enhancing as long as you're very clear in your articulation, the speed at which you talk, and the volume. So if you are from a foreign country and have an accent, being very clear and even asking patients if you are understandable to them. I want to present some very interesting research that was done by Nalini Ambati and her crew on voice qualities. So what they were looking at was, can the vocal be a predictor of whether or not a surgeon would be sued? They had patients listen to 40-second audio recordings of surgeons' voices, and this is what they found. Higher dominance tones, which are deep, loud, moderately fast, unaccented, and clearly articulated speech, correlated with whether a surgeon had been sued for malpractice or not. the results were that these people who listened to these voices interpreted the high dominance tones as having low concern for them, lacking empathy and understanding, and indifference. And indeed, these physicians, it turned out, were more likely to have been sued. On the other hand, the voice qualities that the patients described as concern or anxiety even in the voice, they felt that it was positively correlated to expressing concern and empathy. And the results of this were that these surgeons were much less likely to be sued. So, I hope I've convinced you about the power of the voice, right? So we are almost out of time, or we are out of time. I'm not going to spend time talking about the cultural differences, but they are significant in nonverbal communication, and I hope that you'll spend some time looking into that. In conclusion, before Barbara joins me, I want to just close with a quote that I'd like to expand upon that captures the importance of nonverbal communication. Management guru Peter Drucker said, "The most important thing in communication is hearing what isn't said." I would add to that, the most important thing in communication is hearing and seeing what isn't said. So thank you very much for your time. I welcome any questions you might have. If you want to contact me, I'm going to give you my contact information. And Barbara, the platform is yours.
Okay. Thank you very much. That was absolutely fascinating, Joan.
Thank you.
So I'm sure you all know the evidence-based importance of communication, and Joan actually mentioned some of these as well. I just wanted to give you a quick overview of .com. The 42 modules that we have were written by leading faculty. We have over 40 CME MOC credits and over 400 realistic videos, which our learners absolutely love. We also have annotated interactive videos. And then we have a whole back end for faculty to do assignments, grading matrix, resources, curriculum guides. Our modules are all consistently the same. They have key concepts, learning goals. Videos are interspersed with a behavioral checklist. And here's the annotated video, for example. You can go down through and see what highlighted here is exactly what the person is talking, the clinician is talking about. And then if you click on the icon there, out pops the clinician, and he'll actually tell you what's going on in the back of his head. We have these comprehension scores where you can test your empathy, understanding. Here's the clinician interacting with the patient, and you click down here on where you think an empathic comment should be made. This is one on facial recognition, checking which box is the facial expression. We have a facilitator guide, a syllabi, administrative guide. And if you would like a free 1-month trial subscription, I'm going to bring up a code in just a moment, but we also have free resources. We have webinars, which Jones will be one of. And she's actually just done a podcast as well, Clinicians in the Language of Nonverbal Communication. Our podcast is Healthcare Communication Effective Techniques for Clinicians. Comes out every Saturday morning. It's about 25 minutes in length, and we have near 2,000 downloads so far, and we've been getting a lot of good reviews on that. So here is the code. It's WEB-JUN18. If you would like to activate your free trial subscription, just go to .com.org and put in the code when you're prompted, and you'll get a free 1-month trial subscription. Thank you, everybody, for listening, and we hope that you'll be back for our next webinar. And thank you again, Joan.
Oh, you're most welcome.